Hello, and welcome to this webinar on complex and rare epilepsies, the past, the present, and the future, organized by the Pediatric Commission of the International League Against Epilepsy, the ILA. This is the third webinar, and it's part of a series of webinars with educational purpose, one of the main objectives of our commission. My name is Kette Valente, and I'm the current chair and a member of this commission, as all speakers in this webinar. This webinar was presented as a session at the International Epilepsy Conference in Dublin and addressed the current state of the art of the developmental or epileptic encephalopathies, considering diagnosis and treatment. Developmental and epileptic encephalopathies are complex and rare epilepsies, leading to a relevant burden to patients, families, and society. Delving into the recent advances considering terminology, phenotype, and genotype is vital to earlier diagnosis and tailored treatment of these disorders. Besides, although only 5% of all rare disorders have adequate treatment, 30 to 40% of all medications that have been developed in the past 5 years target rare diseases, including developmental and epileptic encephalopathies, a growing and expanding field of research. We believe that this webinar is essential for healthcare providers in charge of children, adolescents, and adults living with hard-to-control epilepsy, namely developmental and/or epileptic encephalopathies. The speakers of this webinar have consistently recognized the importance of developmental and epileptic encephalopathies and have over the years given an undeniable contribution to their understanding. Therefore, it is an honor for the Pediatric Commission to present this session. Our first speaker is Professor Elaine Wirrell, followed by Ingrid Scheffer, Nabbout, and Georgia Ramantani. I just would like to say that all questions that you may have, you should address in the Q&A. The chat is closed for the audience, so please put your questions and we'll be responding or answering at the end of these presentations. So the first speaker that we have is Professor Elaine Wirrell. Professor Elaine Wirrell led the 5 manuscripts that delineated the last classification of epilepsy syndromes. After this great piece of work, there were some questions about the term developmental and epileptic encephalopathies, and even the inclusion of so many monogenic developmental and epileptic encephalopathies as epilepsy syndromes. In this context, I would like to invite Dr. Elaine Wirrell to present the lecture From Catastrophic Epilepsies to Developmental and/or Epileptic Encephalopathies. What is in a name? Do words matter, Elaine?
Thank you very much, Kette. And welcome everyone to our webinar. So my talk is really going to be looking at the terminology. And so it's entitled, as Kette had said, From Catastrophic Epilepsies to Developmental and/or Epileptic Encephalopathies. Really, what is in a name? And here are my disclosures. So I'd like to review what we mean by the term catastrophic. If we tell a family that their child has catastrophic epilepsy, what is their understanding of that? And then we'll look at what is really meant by the term developmental and epileptic encephalopathy, and I'm going to call it DEE. We'll look at some of the outcomes of concern in children with DEEs and really ask the question, are they really catastrophic? Is there absolutely nothing that can be done? So when we look at the term catastrophic, this is not a medical term. If you go to the Merriam-Webster dictionary, what is said is that this is a momentous, tragic event ranging from extreme misfortune to utter overthrow or ruin. And another definition is utter failure. And I think this really denotes a very strong sense of hopelessness for the family. If you look at this, I mean, it's really, really a hopeless situation. And I would say that the term catastrophic is not a word that we want to use to describe any child. Let's look at the terms developmental and epileptic encephalopathy and what do those mean? So the term developmental encephalopathy implies that the encephalopathy that we see is a direct cause of the underlying etiology. So it arises directly from the underlying etiology, not the seizures. And thus, even if we could improve seizure control and we could clean up the EEG, that probably would not impact the encephalopathy, the developmental encephalopathy. However, if we have therapies that really target the underlying pathogenesis, and I think importantly, if we use those therapies very early on, the hope is that we may be able to improve developmental and encephalopathy. The term epileptic encephalopathy implies that it is the frequent seizures and or frequent epileptiform discharges that leads to the encephalopathy. And so the encephalopathy that we would see would be over and above that, what we would expect from the underlying cause alone. And if we can improve seizure control, that will improve the epileptic encephalopathy component. In reality, children who have DEEs in most cases have both a developmental and an epileptic encephalopathy. And so it's really both the frequent seizures as well as the underlying cause that is impacting on their development. Now, when we look at the developmental and epileptic encephalopathies, these are individually rare disorders, but they in fact collectively are not that rare. And you can see here that we can think about them as specific syndromes. And I would refer you to the excellent papers by Zuberi and Specchio that really denote the definitions of each of these syndromes. So early infantile DEE, epilepsy in infancy with migrating focal seizures, infantile epileptic spasm syndrome and Dravet syndrome coming on in infancy, and then childhood onset epilepsy with myoclonic atonic seizures, Lennox-Gastaut, DEE with spike wave activation in sleep, HHE and fires. And then we have a bunch of different etiological based DEEs as well, many of which are genetic. And I think importantly, when we're seeing a child with a DEE, we need to think about both of these. We need to ask, is there a syndrome that we can identify? And is there an underlying etiology? And many children, you can identify both a syndrome and an etiology. And Ingrid is going to really talk about some of those specific genetic etiologies. And I think for the future, that's going to be really critical in choosing a best therapy and potentially a disease-modifying therapy early on. So let's look at the specific DEEs and their outcomes. The youngest or the earliest DEE that we see is early infantile DEE. And this begins always in the first 3 months of life with frequent drug-resistant seizures. The mandatory seizure types are tonic or myoclonic, but these babies also often have other seizure types, including epileptic spasms. And these children always have an abnormal neurologic examination with hypotonia, cortical visual impairment. Many of them will have movement disorders. The EEG is severely abnormal. Often it shows a suppression burst pattern, or it can show some diffuse slowing with multifocal discharge. And when we look at the outcomes of these children, this is very concerning. So looking at the seizures are usually drug resistant. Some of these babies may evolve to infantile epileptic spasm syndrome. When we look at the development, nearly all have moderate to profound intellectual disability long-term, And many have associated movement disorders, as I had mentioned, cortical visual impairment. Feeding and respiratory problems are very common and can lead to recurrent problems with aspiration. And these children have high mortality. Most of the deaths occur early in life, and most are not due directly to the seizures, but rather to the profound neurodevelopmental disability, and aspiration pneumonia or other infections are very common causes of death. So clearly this is bad, but there are some etiologies that have specific treatments and the hope for better outcomes. So we can identify some genetic causes that really do help guide treatment. For example, KCNQ2 encephalopathy, sodium channel blockers or ezogabine can improve seizures, maybe improve development, and there's some agents that are in development for that. SCN2A encephalopathy early on responds very nicely to high-dose phenytoin. These are gain-of-function variants. And then the vitamin-dependent epilepsies, where if we use pyridoxine or pyridoxal 5-phosphate, that can alleviate seizures or significantly reduce seizures. So here is a 1-month-old girl with early infantile DEE. So she initially presented very early in life, just a couple of weeks of age, with focal seizures with left eye deviation, tonic extension of her left upper extremity. And then you can see here, this is a video of her after she has developed epileptic spasms, and she's having little clusters of epileptic spasms. And these developed at about a month of age. She had poor visual attention. She had global hypotonia. And we put her on vigabatrin, which controlled her seizures for about 3 months. But then she broke through and she was having very, very frequent focal seizures. And with that, we had tried a couple of other medications. She was drug resistant and really started showing a significant developmental regression. Looking at her imaging study, as you can see here, on the axial T2, we see a hypointense region. With a corresponding abnormality on MP RAGE, and this was consistent with a focal cortical dysplasia. She had an epilepsy gene panel, which was negative. And this was her EEG. This is the interictal EEG. And you kind of see here that it's a little bit of a suppression burst kind of flavor to it, not completely suppression burst, but we see this discharge that is predominantly in that right central temporal region where the abnormality on MRI was. And then this was her EEG during spasms. And again, we can see that there's clear focality coming from that area of the focal cortical dysplasia. So does she have a DEE and is it bad? And I think we would all agree, yes, this is a DEE. And yes, it's bad. Clearly, she's having drug-resistant seizures, many per day. Her development is regressing. So is it catastrophic? Is it really, there's nothing that we can do? And I think, and Georgia will talk a little bit more about this, this is not catastrophic. We can actually do something. This is focal cortical dysplasia. And so she underwent a right frontal resection tailored with intraoperative ECOG. And you can see her here. So she does have a slight hemiparesis of her left side, but I think looking at this child, we would definitely not use the term catastrophic for her. She's a delightful little girl. So moving on to infantile epileptic spasm syndrome. This is probably the commonest DEE that we see in infancy and presents with clusters of flexor, extensor, or mixed spasms, as this child is illustrating, between the ages of 1 and 24 months. We see here a very abnormal EEG. Most of these children, not all, but most of them show this hypsarrhythmia pattern, high amplitude, multifocal discharges, often periods of decrement. And this has a very broad range of etiology. So again, a good illustration of you need to look at the syndrome, but you need to look further at the underlying etiology. So looking at long-term outcomes, and this was very nicely delineated by Rakonen et al. So seizures, the spasms usually stop before 3 years of age, but many of these children develop other seizure types. In fact, long-term, only a third of these children achieve seizure freedom. 55% have drug-resistant epilepsy, and 18% have evolved to Lennox-Gastaut syndrome. So the seizures are often bad. Looking at the development, so of survivors, only 20% are normal, and about 3/4 have moderate to severe intellectual disability. The vast majority are markedly or completely dependent on others for care. And looking at mortality in Rakonen's study, a third had died by early adulthood. So again, it's bad, but can we do anything to improve the outcome? And a couple of things we can do. So first of all, we need to be able to recognize spasms and treat that with a standard therapy in a timely manner. So this is nice data from the United Kingdom infantile spasm study. And what it shows here is they looked at the Vineland Adaptive Behavior Scales. This is a assessment of development. Higher scores are better. And you can see here, looking at the lead time to treatment, the shorter, the quicker we identify and treat, the better that child's development long term. So less than 8 days, here's the score, more than 2 months, and you see a much lower score. And that was particularly true for those babies who had no identified etiology for their spasms. The other thing that's really important that we do is choose standard spasms therapy. So we don't want to be using our usual anti-seizure medications. This is data from Zach Greenspan from the US infantile spasm study. And you can see here that if you choose ACTH instead of a non-standard therapy, much higher likelihood of freedom from treatment failure. That is also true for oral steroids and for vigabatrin. So we need to be using those standard therapies, high-dose oral steroid, ACTH, or vigabatrin, and vigabatrin particularly for tuberous sclerosis. And there's been data from EpiStop to suggest that if we identify these children early with tuberous sclerosis, and we look carefully for epileptic discharge on their EEG, that if we start vigabatrin preventatively as opposed to waiting for their first seizure, that may also lessen the severity of their epilepsy. There was a trend towards a lower risk of neurodevelopmental delay in this study, but that was not significant. Now, the PREVENT study has since come out and they did not find quite the same results. So I think this needs further work, but I think it is of interest and I think really tells us we need to be identifying these patients early. And then the other thing that we need to think about is for children who have infantile epileptic spasm syndrome who are drug resistant to standard therapies, are they surgical candidates? And if they are, we want to move them to surgery more quickly. So this is older data now from the UCLA group, but again, they're looking at the post-operative Vineland. So again, higher scores are better. And you can see here, the longer we wait to do surgery, the poorer that child's development. So again, if we identify that these children are drug resistant and they are surgical candidates, we need to move them towards surgery quickly. So let's move on to Dravet syndrome. Dravet syndrome is also a very severe early onset DEE, beginning between 1 and 20 months of age. The seizures are typically hemiclonic, febrile, and afebrile. They are often prolonged, and one of the clues is a child who has a prolonged left-sided hemiclonic seizure and then comes back within a couple of weeks to a couple of months now with a prolonged right-sided. So oftentimes those seizures alternate size from seizure to seizure. These children can also have focal to bilateral tonic-clonic or generalized clonic seizures. And as they age, other seizures can evolve. And we know that triggers are very common, so particularly fever, post-vaccination, or excitement. And many of these children, in fact, the vast majority, will have pathogenic loss of function SCN1A variants found. So looking at the long-term outcome, this is data from Chiron et al. From a large French group, and then also some mortality data from Cooper. So seizures, 95% of ongoing generalized tonic-clonic seizures at least annually, long-term. And in fact, half of those have convulsive seizures more than weekly. Looking at the development, by adulthood, 2/3 of them have severe intellectual disability and half are completely dependent on others. And then mortality data from Cooper, the overall mortality was about 16 per 1,000 person years. The commonest reason for mortality was SUDEP, and that was about 9.3 per 1,000 person years. So again, it's bad, but can we do anything to improve the outcome? And I think we can here. We want to make an accurate early diagnosis. We know that for Dravet syndrome, there are contraindicated medications, and particularly the sodium channel blockers should not be used. And given that these children present with focal seizures, that's often sort of a reflex thing that we often do, right, is reach for a sodium channel blocker. But if we recognize this as Dravet, it should not be used. This is data from the Netherlands, and what they showed is that children who were treated with a longer duration with a sodium channel blocker, a contraindicated medication, had a poorer outcome developmentally long-term than children who were treated with a shorter or for a shorter duration or not treated. So again, this impacts not only poor seizure control, but likely impacts long-term development. And again, we know that there are now a number of drugs that have been studied in randomized placebo-controlled trial with proven efficacy in Dravet. So stiripentol, you can see here in dark blue is the proportion of patients achieving greater than 50% reduction with the actual agent versus the light blue placebo. And then in dark green, if we look at a higher bar of efficacy, greater than 75% reduction seen with the active agent versus placebo. And you can see here, particularly for fenfluramine, the very significant benefit that we can achieve in many children. So then the question is, if we use a best therapy early on, does that actually make a difference? And again, the group from RIMA and Catherine Chiron looked at this. This was a retrospective study just published earlier this year of 131 infants who started stiripentol before 2 years of age. And what they found was that those starting stiripentol before 2 years of age actually had reduced frequency of prolonged tonic-clonic seizures and status epilepticus, and it was well tolerated. So again, it does make a difference if we use this early. And then this other study is looking at adults, and it looked at the seizure burden in adulthood, comparing if you started stiripentol before 15 years, and that was in blue, to those starting stiripentol after 15 years, and that is in orange. The top graph here is the number of generalized tonic-clonic seizures during the last month. And again, you can see a higher seizure burden in those who started stiripentol late as opposed to early. And then this bottom one is the patients who had generalized tonic-clonic seizures lasting more than a minute. And again, we see a poorer outcome in those starting stiripentol later as opposed to earlier. So it probably makes a difference to use a best medication earlier on. We also know that it's not all about seizures. And so this was a post hoc analysis of children in the fenfluramine open label extension study. And what they did is they correlated seizure control with their executive function using the parent completed brief. And you can see here in green are patients who had a greater than 50% reduction in seizures, and in gray, those with a less than 50% reduction in seizures. And then the behavior rating inventory, emotional, cognitive, and then the global executive. And what we see here is significant improvements in the emotional regulation index and the cognitive regulation index in those with better seizure control, and a non-statistical, but certainly a trend towards improvement in the global executive. So that does suggest that improving seizure control can also improve some of these non-seizure outcomes. And we know that disease-modifying therapies are really on the horizon, and these are very, very exciting treatments. Currently, there is a trial ongoing looking at an antisense oligonucleotide by Stoke Therapeutics for Dravet syndrome that is ongoing now in children between the ages of 2 and 18, using doses between 20 and 70 milligrams, either as single or multiple ascending doses. And they did present some interim analysis at the Dublin meeting. And what they showed was that there was a dose-dependent reduction in convulsive seizures. And at the 70 milligram dose, they actually had an 80% reduction in seizure frequency at 3 months. And then they also looked at comorbidities, and the comorbidity data was not looked at from the 70 milligram dose. That is going to need a little bit more follow-up, but they looked at the lower doses, and they did find that there was improved communication, gross motor skills, and executive function compared to natural history controls. So that's very exciting and suggests that if we have a disease-modifying therapy, we might be able to, reduce seizures, but also lessen comorbidities, and probably time is going to be really important. And there are now some other therapies that really are targeting DNA and RNA in development. And then can best therapy actually reduce mortality? So I've already talked about the Cooper study that showed a SUDEP rate of 9.3 per 1,000 person years. This is, again, post hoc analysis from the fenfluramine data. They looked at the person years of exposure to fenfluramine and actually documented a lower SUDEP rate than Cooper had reported. And so again, suggesting improved seizure control may also benefit with a significant reduction in SUDEP. So to conclude, the developmental and epileptic encephalopathies absolutely do have worrisome outcomes regarding seizure control, regarding the children's development and mortality. I think we still have quite a bit to learn, and we still need to ensure that we employ our multidisciplinary teams to optimize care, because these children have multiple comorbidities that need to be addressed. But I think we've come a long way. We have a much greater understanding of the pathogenesis, and particularly many of the genetic causes, and Ingrid is going to talk about that next. And I think those are going to allow potential targeted treatments with either new or repurposed medications, some of the emerging new genetic therapies. Georgia is going to talk about greater surgical options in early life, really to improve outcome. And then I think that there also is potentially a role for neuromodulation to prevent the abnormal network development. So I would conclude that words do matter. So whatever words we utter should be chosen with care. For people, including parents, will hear them and be influenced by them for good or ill. And so we can make a difference, I think, for many children with DEEs. And I think the future actually looks much brighter for those children. And so I would argue that these are not catastrophic. Thank you very much.
Thank you, Elaine. It's always a great presentation. And our next speaker is Professor Ingrid Scheffer from Australia. And Ingrid has dedicated her life to properly delineating the phenotype of patients with developmental and epileptic encephalopathies, namely Dravet syndrome. Actually, Dravet is her middle name now, and its correlation with genotype. She will address the relevance of an in-depth knowledge of the profile of these patients beyond seizures and EEGs in the context of a more etiology-driven approach, heading into a new direction with this. So, Ingrid, I pass
to you. Thank you very much, Kette. That's very kind. And good morning, good afternoon, and good evening, depending on where you are in the world. And I'm excited to talk to you about how the direction in which we're headed, which is an etiology-driven approach. Here are my disclosures. Now, I'm going to belabor the point that Elaine made about the definition of the developmental and epileptic encephalopathy, really from a conceptual point of view and in a few slides. And here we're considering three elements: etiology, epileptiform activity, and developmental impairment. And just starting with the concept of an epileptic encephalopathy, here we're in a position where you have an underlying etiology causing frequent epileptiform activity, and that epileptiform activity adversely affects the baby's development with developmental slowing and typically regression. And here you see a little identical twin from India who I care for, and you can see her having a cluster of epileptic spasms as part of the infantile epileptic spasm syndrome, and she has the classical EEG of hypsarrhythmia. And interestingly, we were able to start treating her identical twin before she manifested spasms, but when she already had the finding of hypsarrhythmia or evolving hypsarrhythmia. So that's an epileptic encephalopathy. We want to expand this concept now to introduce the term developmental and epileptic encephalopathy. And the idea here is that the etiology contributes to developmental impairment in its own right, as Elaine has said, and in addition causes this epileptic encephalopathy process. And really our prototype of a DEE is Dravet syndrome. It's due in more than 90% of individuals to a pathogenic variant in SCN1A, and that encodes the alpha-1 subunit of the sodium channel that you're seeing here in sort of pinky purple, through which the sodium ions pass. You see it embedded in the cell membrane. And I've just got here a 6-year-old with a Dravet syndrome and a relatively normal gait, and then a 28-year-old here who has the very severe crouch dystonic gait that you see in some individuals as they grow older. And this is a manifestation not of the epileptic encephalopathy, but of an effect of SCN1A on their developmental trajectory. Now, we have a host of developmental and epileptic encephalopathies, and Elaine's described some to you. The most frequent, of course, is infantile epileptic spasm syndrome, Lennox-Gastaut syndrome, Dravet, and epilepsy with myoclonic atonic seizures. But that's not all. We have a number of other syndromes, and they include rare syndromes such as developmental and/or epileptic encephalopathy with spike wave activation in sleep, of which Landau-Kleffner syndrome is really our poster child. And you heard about epilepsy of infancy with migrating focal seizures. We also have some that are more focal in nature, such as tuberous sclerosis and Rasmussen syndrome, some that begin older at progressive myoclonus epilepsies, and there are now many genes known for those. And in the latest classification of syndromes that Elaine shared, we actually decided it made sense to merge Ohtahara syndrome and early myoclonic encephalopathy because it's very clear these are a spectrum. And we have called this early infantile DEE, which begins by 3 months of age. And we've heard a lovely description of that from Elaine. Now, there are a couple of other points. There are still many patients that don't fit neatly into one of these boxes. So I like to see them think of them as being this blue here, the blue C around the boxes. And just to say that you can make a diagnosis of a developmental and epileptic encephalopathy, even if you can't make a diagnosis of a specific epilepsy syndrome. And it will affect how you treat the patient because you will treat them more aggressively in terms of medication, looking for other features. And most of these syndromes have a range of other features, which we refer to as their comorbidities. And although when we start, a lot of attention is focused on seizures, with time it becomes very clear that most of these children will have developmental problems because they must slow as part of the definition of an epileptic encephalopathy, but they'll often regress and they may take time to improve. And often they don't catch up to where they were. Behavioural problems, mood disorders, psychosis can all occur, but behavioural problems would be the most significant. And of course, autism spectrum disorder. Gait problems can evolve with time, or maybe some will never walk. And so gait and a range of musculoskeletal problems, such as scoliosis, can occur. Often they have gut problems. They may have feeding difficulties, constipation, diarrhea, and sleep problems affect the child and usually the family. So really pervasive issues, far more than just seizures. And when we're thinking about making an etiological diagnosis and hopefully getting precision medicines, we want that precision medicine to treat all of these symptoms and all of these medical problems, not just the seizures. So we brought out a new framework through the ILAE for how we think about epilepsies, and it's important to consider this with every patient that you see. The framework begins by trying to determine the types of epileptic seizures that your patient has. Are they focal? Are they generalized? Or are you not sure? And then can you classify which seizure type? From when you first see a baby or an infant or a child with seizures, you need to consider etiology. Can you determine what the etiology of their epilepsy is? And we made these 6 boxes. It's not comprehensive, but we've focused on those where there is the most we can do about them. And that landscape is rapidly changing as we discover more insights into genetics and interactions with environment. We also try to diagnose the epilepsy type for every child you see, and we brought in this new box, combined, generalized, and focal, and then also, where you can, the epilepsy syndrome. A major emphasis was that the whole time you see a child, you must think about the comorbidities. What other features are there this child might have that you should be looking for and addressing from a medical perspective? And then when you think about this more broadly, we try to introduce the developmental and epileptic encephalopathies into this rubric. And you can see they really go across all the epilepsy types as well as the syndromes. But the most frequent group they fall into are the combined, generalized, and focal. So that's our framework. That's what the DEEs are and how they fit in. But is it that simple? And the answer is sadly no. So the reason it's not that simple is that we now know that most epilepsy syndromes actually have a phenotypic spectrum, ranging from self-limited epilepsies for many genes, but not all, and developmental and epileptic encephalopathies. And we now know in our recent curation of all the monogenic epilepsy genes, my colleague Karen Oliver found that there were over 925 robust monogenic epilepsy genes. And if we think about the developmental and epileptic encephalopathies, more than 825 genes are implicated. So really most of the monogenic genes that we know are for DEEs. And today, if you see a child with a DEE and you're in a fortunate enough position to be able to access genetic testing, we will solve 50% of the patients, which is coming a long way when you think until the year 2000, people thought these were not genetic. So why does all this matter? Why are we talking about finding the cause, getting a precision diagnosis, and then taking it to precision medicine? Well, we've got to remember that these families are on a huge diagnostic odyssey. They're really worried about their very sick child or baby, and they're trying to find out, why is my child got this disorder? And I like to frame the genetic answer as really the genetic finding as the beginning of the answer. It's not the whole answer. The whole answer would be if we could cure their child, but it's just the beginning. This is why my child is sick. It's not anything I did. It's purely bad luck. What else does it do? Well, a precision diagnosis informs comorbidities. You will know that, say, 40% of children with this particular gene have autism spectrum disorder. Therefore, look for it early, get resources and management in place. It informs prognosis. How long do most of the children live? We know in Dravet syndrome that it has a 17% mortality by 20 years of age. We know in other syndromes it's worse than that. And will the child be likely to have drug-resistant seizures? And finally, how does it help? Well, it helps you to optimize your treatment, to use the right drugs and not the wrong drugs, as we heard about from Elaine. So you never use carbamazepine or oxcarbazepine in Dravet syndrome. And it also helps you to give often quite young parents genetic counselling so that they're not at risk of having a second affected child with the same disease if they had, say, germline or gonadal mosaicism. So the question that we should be asking ourselves, and I know many of the genetics people would like us to do this, is to move from an epilepsy syndrome diagnosis to an etiological diagnosis. I suspect we need both. But we are now moving to thinking about an etiology-based diagnosis. And in the recent classification papers published last year, Samir Zuberi led the one on infants and neonates. And here we introduced the concept of etiology-specific epilepsy syndromes, which were due to specific genetic, structural, metabolic, immune, and infectious etiologies. They had to have consistent electroclinical features, management, and prognostic implications. And most of these etiology-specific epilepsy syndromes began in a young child, so very much the province of the pediatric neurologist. Here are the different etiology-specific epilepsy syndromes that we named and described in those papers. And we just began with 8, although there will be many more to come. Now, I thought I would just use 2 examples of these so you can see how it begins to fit together and how we need to think about these syndromes moving forward. So let's start with KCNQ2, early infantile DEE, and you can see here the potassium channel that is responsible for the M current, which keeps the cell membrane at the same potential. Now, KCNQ2 EIDEE usually begins in the first week of life, so that's why we call it early infantile, and often with focal tonic seizures or clonic seizures. And you can see this little baby having little focal clonic seizures involving his left arm. Then next to him, you see the same child. He's now quite a bit older, about 2, and you can see him having a tonic seizure, which he doesn't like. There it is now with the sort of star-shaped bilateral upper limb abduction, facial grimacing, and he found that pretty uncomfortable. So this KCNQ2 early infantile developmental and epileptic encephalopathy has a fairly classical pattern of beginning mostly in the first week of life with tonic seizures. They also can have focal, tonic, clonic, myoclonic seizures and epileptic spasms. They have profound impairment, as with this little boy here, where you can see he's got spasticity, he's nonverbal and non-ambulant. He has axial hypotonia, peripheral spasticity, and they also get dystonia. And they have a classical EEG finding of burst suppression on their EEG, but they don't have to have that. They may have just very active epileptiform activity. They have a missense mutations of KCNQ2, and seizures, whilst being really severe at the beginning, often settle down by about 4 years of age, although they are left with profound impairment. That happened to this little chap I'm showing you, but by 8 years of age, he had a picture that had evolved to Lennox-Gastaut syndrome. So apparently seizure-free for a while, but then it came to Lennox-Gastaut syndrome. So let's look at these etiology-specific syndromes. I'm going to describe another one of these to you now. And here I wanted to show you the older brother and the younger brother. So at the top, you see the 7-year-old boy who was a bright boy of normal intellect with childhood absence epilepsy, classical EEG, classical absence seizures. His brother had had absence seizures at 3 years of age, which had settled. He's now about 15. And he's developed these adolescent attacks after about 15 minutes of exercise, where his legs move uncontrollably and he's unable to walk during these periods. So these are 2 brothers. Here's an unrelated boy who has a much more severe developmental and epileptic encephalopathy picture with frequent absence, myoclonus and tonic-clonic seizures. You'll see a myoclonic seizure in a moment, and severe intellectual disability with just 1 to 2 words that he can speak. And there you see his myoclonus. Now, these boys all have a mutation of the same gene, although they have very different phenotypes. And the gene, I hope you've guessed it by now, is SLC2A1, which encodes the glucose transporter 1. Now, what's important to know about this gene is that it has a huge phenotypic spectrum. And it goes from the GLUT1 developmental and epileptic encephalopathy, which is characterized by drug-resistant infantile seizures and a complex motor disorder, to affecting 5% of patients with epilepsy with myoclonic atonic seizures, 10% of those with early onset absence seizures, and 1% of those with idiopathic generalized epilepsies, and some with focal epilepsy. In the movement disorder space, it causes paroxysmal exertional dyskinesia, which is what that boy, the adolescent I showed you, have. Ataxia is common. They can develop a slowly progressive paraplegia. So there's this pattern of increasing phenotypic severity of epilepsy and movement disorders, and they may or may not overlap. And why does that matter? Well, this precision diagnosis with SLC2A1 pathogenic variants has a precision therapy, which I hope you all know about well, which is the ketogenic diet, because that offers an alternative pathway for energy substrates for the brain. So we are moving from the picture of an epilepsy syndrome to an etiology-specific epilepsy syndrome with precision diagnosis. And this has the promise of precision medicine, which will treat all the disease features, not just the seizures. And today that's also relevant in terms of the anti-seizure medicine you might select, but soon it will be relevant for gene therapies. But I wanted to show you that because of the spectrum of phenotypes for a genetic etiology, knowing the gene etiology on its own is just simply not enough, because one gene, such as SCN1A, results in many syndromes, from the self-limited syndrome of genetic epilepsy with febrile seizures plus to the developmental and epileptic encephalopathies. And even within them, it causes a range of DEEs, of which we know Dravet syndrome the best. But if you take epilepsy of infancy with migrating focal seizures, we found in a large international collaboration that is actually associated with 33 different genes, including SCN1A. And we've already heard a lovely description of the complex phenotypic puzzle of Dravet syndrome. And we know that Dravet syndrome has seizure exacerbation with sodium channel blockers such as carbamazepine and oxcarbazepine. We still don't know entirely whether lamotrigine and phenytoin are bad or bad for some or good, and that still needs further work. In contrast, SCN8A and SCN2A both cause the early infantile DEE, and they do well because they have, with sodium channel blockers, because they have gain of channel function. So therefore, blocking the channel is a good thing. I'm going to skip through this because I think some of that's been dealt with. I wanted to say with SCN1A, though, we have a very broad phenotypic spectrum, and we're understanding now that we have many more phenotypes that are associated with gain of function, this early infantile SCN1A DEE, and epilepsy of infancy with migrating focal seizures. And you can have focal epilepsy with a normal intellect and hemiplegic migraine that are all due to gain of function, as distinct from those epilepsies due to loss of function, including self-limited epilepsies and DEEs. So we need to think about it differently, and we need to think about epilepsy syndrome, etiology, say a gene, and understand the functional impact of that gene when we consider our epilepsy syndromic spectrum. So we don't want just an etiology-specific syndrome, we want an etiology-specific epilepsy syndromic spectrum. And if you think about someone with a malformation, they will have abnormal networks and may have causative genes, which means they will also have an etiology epilepsy, specific epilepsy syndromic spectrum. So to manage a patient, when you see a patient in your clinic, knowing the gene is not enough, knowing the pathogenic variant in the gene is not enough, you need to understand the syndromic spectrum of that gene. You need to understand the functional consequences of that exact pathogenic variant, and you understand how all this comes together to determine your treatment approaches. I'd like to conclude by thanking the colleagues with whom I work, both with my own team internationally and most importantly, the patients and families. Thank you for your attention.
Thank you, Ingrid. It's always a pleasure to see Ingrid develop her slides. She is the Spielberg of our slides. Well, let's move to Nabbout, Professor Nabbout, who embraced the difficult task of presenting the challenging topic of transition in epilepsy, still neglected, namely in children and adolescents with drug-resistant epilepsy, especially when associated with intellectual disability and/or autism spectrum disorder. Professor Nabbout is well known for her contribution on Rare, consolidating some of the most important concepts about this condition, diagnosis and treatment. And she'll be addressing today the unmet needs in transition to adult care in DEEs and complex epilepsies. Are we prepared to transfer these patients properly to adult life? And how can we do it? Rima, the best.
Thank you, Kette, for this kind introduction. And thank you for all for being with us today. Indeed, my topic will be about transition, and maybe it needed some years to get into this topic, especially when we see our patients becoming older, and that we see that our patients, they have their needs, and sometimes these needs might not be fulfilled completely during this period and after the transfer. So here are my disclosures. I wanted just, I already stated the transition and the transfer, and I wanted just to emphasize that when we are talking about the transition, we are talking about this process where this is something that is planned, that can address the different aspects of the needs of an adolescent and young adult, beginning from a period in childhood and getting till this point that is the transfer. And the transfer is this formal event that sometimes might take 1 or 2 visits, but it's not I would say, a long process when the healthcare of this younger person moves from children's services to adult services. And as you know, we have this concept, we are in pediatrics in general, we battled many years to make the understanding that children are not little adults. And finally, this concept was accepted in many issues, especially in medicine and some medical fields. And what is also important, that there are needs for those adolescents with epilepsy that are already, there are advocacy for these needs at the level of the IBE, but also at the level of United Nations for all youth, for all young people that have diseases or not. So when we add to these complex epilepsies that you heard about, you can imagine that the situation can be more important. But what I want to discuss today with you is really to see things the other way around. So that adults, although I like Walt Disney and what they did as movies, adults are only kids grown up. I mean, we cannot agree on that, because adults are not only kids grown up, like kids are not only small adults, and adults are indeed different from children by anthropometry, by physiology, by cognitive processes, but also by some gene expression, by risk exposure, and many society issues that are important to know. And the point that is important today, and sometimes we wonder, I mean, like, where were those kids who became adults with these diseases? And we know today that there is a need for the continuation of care, because many DEEs and many complex epilepsies that Elaine and Ingrid showed to you, they are compatible with survival into adulthood, even if there is a higher mortality than in other epilepsies and then in healthy persons. And there are studies estimating that over 70% of children with monogenic epilepsy likely need neurological care into adulthood. And what is important to understand that in this period, what is mainly, I would say, the most important part is the lack of data in this period of transition and in those young adults. Ingrid showed you very nicely all of this work on the phenotyping that many of us pediatric epileptologists worked on. And from the other side, we are beginning in the adults to understand the deep phenotyping or the clear natural history of those patients. So what I wanted to share with you today, that we were talking about this personalized medicine. We are talking about the genetic etiologies, as you saw, but really transition is also a personalized process, and no size fits all. Just thinking about the different syndromes and the different syndromes outcome, thinking about the complexity and the different needs that might be different for different epilepsies, thinking also about the local context of care. And maybe some of you sharing with us this webinar today, you are just smiling and saying, but Rima, those kids in my country, they are seen by the same doctor all over their life, even when they are adults. But even in this situation, when you think about it for some aspects, there is a need for transition. And finally, the gender, with all what we know today about the impact of some medications, but about also the impact of these complex epilepsies in the life of adults with epilepsy. So coming from there, I will show you some examples about why there is a need to think and to really do a proactive transition. Because we know very well, and if we stick to the seizures, that there is a change in the seizures. In many of these patients, thinking about Dravet syndrome, we will see much less, for instance, day seizures. We will see more seizures, tonic-clonic seizures during nighttime. Patients will tell you, or families, that they have less myoclonic seizures, and so on. The duration, keeping with Dravet, of the status epilepticus, very frequent, the long-lasting seizures during the early childhood will really be less important during adulthood. The trigger factors might also change, and definitely the impact might change also. And in many patients, the frequency of the seizures can change, not only because of the therapies, but also because of the natural history of the disease. And this immediately makes us thinking about the seizure therapies. What we know today, that there are some development, and you heard about some of them, of new therapies for some DEEs. And these therapies, if you get back to the papers and to the protocols and the trials that were done, the big majority of the patients that were enrolled were children. So pediatric epileptologists and neurologists, they acquired much more experience with some drugs. I quoted the fenfluramine, the steripental, cannabidiol, vigabatrin. Ingrid told you about the GLUT1 and the ketogenic diet that is used there, but also in other pharmacoresistant epilepsies. So using less some drugs will give less clinical expertise. That is, as you know, very important for understanding how to do for the best the titration, how to understand the interactions, and we should know that the impact of some adverse events can be different or more impactful in some situations in the adults, when we think about depression, when we think about decreasing of the appetite, etc. And I will not emphasize, we know all the particular attention to the contraception and the childbearing girls with some of these medications. So we talked about the seizures, but you know very well, and you listened to the talk of Ingrid, that we have also all of these non-seizure comorbidities or non-seizure symptoms and problems, disorders that these children will present. And here in pediatric care, most often it is the pediatric neurologist and sometimes with the psychiatrist that they are handling these different issues. Even about the gastrointestinal disorders, you know well that sometimes we handle many of these issues, and we have this multidisciplinarity asking for interventions from other colleagues, things that might not be available in some adult epilepsy centers, although they are very advanced in the knowledge about the epilepsy. Another point that I put here in the blue block is the changes in the coordination of care. Because again, in the pediatric age, it's the pediatric neurologist with the family that are handling this. But who will handle this if we will go to the adult neurologist? And do they have, as I said, these settings? And with the parents that are aging at that time. And I will end maybe this need of this multidisciplinarity, that it goes beyond the medical aspects that I summarized in this circle to the right of the slide, because there is also a huge impact from the social, the legal, the autonomy of the patients, who will be the legal tutor, and the economic impact on the individual and the family. And this is what we usually have the help of the social workers, provided you can have this help and you have social workers. So this multidisciplinarity care should continue, and when it continues, it's really, it can be a good transition and transfer. And I talked to you about where this transfer will happen. I am in a pediatric setting where I need to have this transition to an adult setting, but many of these children becoming adults will not go into the specialized, the referral center in adulthood. Some of them might get back to their general practitioner with the family. I said already that they are aging. Some will go into office neurologist, epileptologist, and others can go to some centers. So again, here our transition and the evaluation of the needs of the patient and the preparation of this transfer should be really very, very well thought. And quickly, I will end showing you how we build a transition program in our institution in Paris. As I told you, all of these stakeholders, all of these people are important to build this program. Definitely the patient and families, the program is centered around them, the pediatric neurologist and the adult neurologist. And we did surveys, we did interviews, and we did many works trying to understand what are the needs, what are the point of view of each of these people. And in addition, and here I would love to quote Peter and Carol Camfield that are now retired, I worked with them with a group of experts, including families, epilepsy nurses, adult and pediatric epileptologists, also to shed the light on the transition. We initiated in 2013, and this effort is ongoing today within the transition task force also of the International League. I will not detail this, But to say that we initiate at 12, 14 years almost, to think that we should initiate the preparation of all of these aspects, we validate before the age of, say, 16, 18, what we have to revise, the genetic etiology, but not only, the new drug, but not only, and we will put also the developmental and psychiatric needs. For instance, the gynecology clinic is very important for girls at that period. And when we arrive between 17 and 18 years, we have our transition summary. We have a very nice tool where we summarize all of this. And the nurse, adult nurse, come to our institution, and we do, in a way, this hand-to-hand transfer, and then the patient can go to the adults, and when he will arrive there, he has already his appointment. So I think that initiating this, we were not alone. There were also different groups working on this. There are some nice reviews that were done recently. And I think that today the transition, as you very nicely said, Kette, is integrated in our needs, in what we should develop in our follow-up, in our care pipeline for patients with complex and epilepsies and DEEs. So I will end with the take-home messages. You understood, hopefully, during this talk that there is no size fitting all, and that the menu should be kind of a la carte. The transition should be done for all. We talked about complex epilepsies, but also other epilepsies. All epilepsies need the transition. What is important that there are these changes in seizure and therapies that are really important in this case, but let us do not forget the additional challenges that might need a high level of coordination and multidisciplinarity. There are, in some papers that I showed you, some transition tools and concepts that can help you to adapt in your proper environment what you can do for transition. And definitely we should empower and educate physicians, but also patients and families about this point. This is to tell you that in our pediatric commission, there is a task force on transition working on some of these aspects, and hopefully we will deliver some additional tools and some additional, I would say, possibilities for you to work on this subject. And I will end here thanking you for your attention. This is my institution, so if you are willing or coming to Paris, please do not hesitate to get in touch, and I will be happy to see all of you. Thank you very much.
Thank you, Rima. It's really hard to address transition. We don't have protocols around the world for that. And this is the hard job of your task force. Thank you so much for accepting this and being a leader on this topic.
Thank you, Kette.
Now we'll be addressing epilepsy surgery. Epilepsy surgery is no longer seen as the last resort for children with drug-resistant epilepsy, especially in earlier ages. Still, we observe an undeniable delay in referring and even considering epilepsy surgery for developmental and epileptic encephalopathies. Dr. Georgia Ramantani has represented an important and loud voice advocating for earlier epilepsy surgery in DEEs as a form of precision medicine that can modify the outcomes of these children. Professor Ramantani is the head of EEG and epileptology in the Department of Neuropediatrics the University of Zurich, and the current head of the Pediatric Epilepsy Surgery Task Force of the ILA. She will address epilepsy surgery in developmental and/or epileptic encephalopathies. Can we predict outcomes? Thank you, Georgia.
Thank you so much for this beautiful introduction, and for underlining the fact that my talk is coming last in this very informative and engaging seminar. But epilepsy surgery in developmental and epileptic encephalopathy is not treatment of last resort, and this is not a treatment that we should think of and discuss with parents after transition. But since this epilepsy start early in life, we should think about epilepsy surgery much earlier, and we should keep in mind that the duration of epilepsy in these syndromes may be very important for the outcomes. So I have nothing relevant to disclose, and I will just start with the scaffold of my talk. My talk is about concepts, and in this part I will reintroduce, I will discuss some concepts that have been discussed in the previous talks, but I think that some repetition will be key to understand what this is all about. And then I will go into some specific syndromes, some syndromes that are amenable to therapy with epilepsy surgery. And then as a last part, I will discuss some new tools that have enhanced our armamentarium of diagnostics and then treatment. So this is a part where I have a bit of a repetition. So we are referring in this talk and also in this seminar to developmental encephalopathy, which is the situation where developmental delay or intellectual disability is due to a non-progressive brain state, but this coexists with epilepsy. And then we have the epileptic encephalopathy. This is what we are hoping for, because we can offer a better treatment, we can cure. And this is the situation where we have abundant epileptiform abnormalities and a high number of epileptic seizures, and they themselves contribute to cognitive regression. And then the last part, the title of the seminar is Developmental Epileptic Encephalopathy. This is more complex because cognitive development and behavior are impaired independently to the epilepsy onset. And of course, these details are actually limiting, or they are giving us the frame of our expectations. So what is the expected treatment effect? The best is epileptic encephalopathy. This is where we know that neurocognition and behavior may significantly improve with the control of seizures and the resolution of interictal epileptiform activity. This is what the parents are hoping for. This is what we are hoping for, that we can stop the discharges and then we can also stop seizures and all will go well afterwards. But we have cases of developmental encephalopathy, coexistence of epilepsy with developmental delay. And in that case, cognitive and behavioral impairments will remain even when we can achieve seizure control. And the last part is that when we have a developmental epileptic encephalopathy, then we may have some improvement, but cognitive and behavioral issues will remain even when we manage to achieve seizure control. And you have to think of these concepts within the scope of decision-making in pediatric epilepsy surgery. This is very challenging. And of course, it's not all about seizure control, although the situation where these children have daily seizures is really pulling the trigger on us. But these children also will have often a West syndrome or infantile spasm. They will have abundant epileptic discharges in EG. They will receive many drugs. They will have a developmental arrest or even a regression. There will be a huge loss of quality of life, not only for the child, but for the family, for the whole system around the child. And this situation will be described by the parents as a nightmare, and then they will expect us to give an end to this nightmare. So what are we aiming for? Of course, we are aiming mainly for seizure freedom. This is what epilepsy surgery is all about. But again, this is not only about seizures, and maybe seizure freedom alone is not an appropriate outcome measure for developmental and epileptic encephalopathy. Because there is much more than that we should be offering, that we could be offering, that we could be achieving in these cases. And of course, we should look for cognitive outcomes, behavioral and emotional outcomes, vocational outcomes, education, vocation later in life. And we should aim at improving the quality of life, not only of the child, but of the whole family. And now I will just point to three important syndromes that can be treated by epilepsy surgery. Starting with infantile epileptic spasm syndrome, where we have spasms, hypsarrhythmia, and developmental stagnation or regression. And this, of course, it's a medical emergency. It's the biggest emergency for pediatric neurology epileptology. And in this situation, we should still look for some features like coexisting focal seizures and a certain asymmetry in epileptic spasms and some consistent focal EEG features, because this should raise the possibility of a structural brain abnormality, and this may be treated by epilepsy surgery. And as Elaine showed in the very first talk of this seminar, there are some excellent seizure and developmental outcomes for children with infantile spasms, and this has been shown almost 20 years ago in this study, where colleagues treated children with active spasms, with treated spasms, and some with no history of infantile spasms. But almost 70% of these children actually had focal cortical dysplasia, hemimegalencephaly, or tuberous sclerosis. And 70% were seizure-free at 1 year after surgery. And this is amazing, because this is what we are giving as chances of seizure freedom to other epilepsy syndromes, and not to develop. We would not think that the rate would be so high for developmental and epileptic encephalopathy. And it's not only about seizures. So as you can see, the post-surgical DQ is given by the seizure duration, and you can see that as the duration becomes longer, there is a drop of what we're expecting as a developmental outcome in these cases. And of course, the developmental outcome has to do with seizure freedom. So those that were seizure-free after surgery had better chances to improve also in terms of cognitive development, and this is very important. So time plays a big role in these cases. And again, in the topic of infantile spasms, and there are expectations for excellent seizure and developmental outcomes. This is a study including 24 children who underwent epilepsy surgery at the age of up to 3 years. And half of them had infantile spasms, and almost 80% had focal cortical dysplasia as the underlying etiology. So again, over 70% were seizure-free at last follow-up, and this is again amazing for this specific group. And you can see that the latency to surgery was crucial for the change in DQ, for the DQ gains, for the gains in cognitive development in these children. So those that were operated early, 1 year after epilepsy onset, had better chances of improving their development after surgery. And then those that had infantile spasms actually did better, maybe because infantile spasms is an emergency. So we tend to offer surgery to treat those patients faster. And this is, of course, again, shortening the duration of epilepsy in these cases. And this is not really surprising, because several studies, and this is one of my favorite, have shown that the duration of hypsarrhythmia itself can determine developmental outcomes. So in this study that was published 20 years ago, they could show that a duration of hypsarrhythmia of over 3 weeks will develop a lower developmental outcome. And again, this is a group of children with infantile spasms, and some of them, 1/5, had malformations of cortical development, and these were not treated by epilepsy surgery, but they were treated with the treatment of first choice, which is steroids, ACTH, and they had a long-term follow-up of up to 13 years. And I am now coming to the second syndrome that I would like to talk about, Lennox-Gastaut syndrome. Again, a very bad situation with multiple drug-resistant seizure types, including tonic seizures with cognitive and behavioral impairments, and then diffuse, slow spike wave and generalized paroxysmal fast activity on EEG. And again, this is a bad situation. It's a very hard to treat epilepsy. But some of these cases may have an underlying structural etiology, including focal or diffuse cortical malformations, tuberous sclerosis, tumors, or acquired brain injury, such as hypoxic ischemic encephalopathy. So there are some structural etiologies that can be treated by surgery. And the results are again excellent. So this is a study including 76 children with Lennox-Gastaut syndrome and 90 children with West syndrome. Some of these cases had resective surgery, some of them had a corpus callosotomy, and you can see that the results are actually very good. So we are between 60 and 62% of Engel-1 of seizure freedom, which is great, especially if we consider the severity of this syndrome. And again, this is not about seizure freedom, but it's about cognitive development. So you will observe the white columns are the pre-operative FSIQ, total IQ values, and the black are the values at the last follow-up. And you can see that before surgery, almost all children were in the below normal range, and then after surgery, the whole distribution moved to a higher range, which is truly amazing. And one very important part is that we should not be discussing with parents that the improvement will come at the day, 1 day after surgery, or 1 week after surgery, because also in these cases it takes time. So you can see that the improvements in total IQ, they may come even after 4 years after surgery, and this is the part where it really becomes crucial. That development is really taking off. And we should not only be thinking of resective epilepsy surgery, because there are some excellent options. For example, vagus nerve stimulation, it can offer a seizure reduction to over half of patients, and corpus callosotomy, it's not something that we offer to all patients, but 74% of children with Lennox-Gastaut had a seizure reduction, so it works. And these are options that we should really be taking into account in these patients. Then, last but not least, I'm coming to a tool that has become available in the last years and has changed our way of thinking about epilepsy surgery, and it will definitely change also the years to come. And this is about genetics. So there are some genetic etiologies which are amenable to surgery and some are not, and this is something that we should really take into account. For example, Dravet syndrome may be limiting the chances of seizure freedom in some cases, and this is a very interesting study that came out a couple of years ago. It's about children who had very clear-cut, beautiful focal cortical dysplasias, and some of them had periventricular nodular heterotopias, and they had the electroclinical features of Dravet syndrome. They had cognitive impairment, they had autistic features, but also the beautiful structural lesions. So 2 of them actually underwent epilepsy surgery. And neuropathology underlined that this was really FCD, type 1A, type 2A, but the seizure outcome was unfavorable. So there was no no seizure freedom and no alleviation from seizures after surgery. So this is a red flag. Even if we have a beautiful structural lesion, we should be aware of the effect of genetics in these cases. And this is, of course, a new pillar in epilepsy surgery workup. So this beautiful diagram came out about 10 years ago, and it's about the tools that we need to make a decision. And you can observe that in almost all etiologies, we will need an interictal EEG, we will need an EEG recording seizures, we will need an MRI, and then there are some other options. But I would suggest that we need also genetics, also in very clear-cut lesions, to be able to predict the outcomes of these patients. So what is to expect in pediatric epilepsy surgery in those who have a genetic cause of epilepsy? This is an excellent review done by the Utrecht group, and they looked at cases with good, poor results, and to those where we can get good results, but we have to pay more attention. So I will start with the good results. Epilepsy due to mutations in the mTOR pathway, and these are focal epilepsies. They will have good results, and we should be offering surgery to these cases. And then there are those with poor results. Those that have epilepsies due to mutations in genes involved in channel function and synaptic transmission. And this is because it's not focal. There is an underlying widespread aberrant neural activity, which is rarely confined to one part of the brain. And then, last but not least, our MRI visible, so those where we have visible structural abnormality, these are cases where we have good results. And if we have MRI negative cases, then we just have to pay attention and we need to do more investigations. We need more information to take the right decision. So to end my talk, what are we hoping for? We are hoping, of course, that we will offer the best chances to each child to be seizure-free and have the optimal cognitive development. And we sort of hope that we will have an epileptic encephalopathy where we can treat the seizure, we can stop the epileptic discharges and have an excellent result. But we should be aware that there are some developmental encephalopathies where we cannot achieve that much. And then we have the complex situation of developmental and epileptic encephalopathy. And overall, we need to define outcomes, and not just any outcome, but relevant outcomes to the child, to the family, to their surroundings. And we need to define the scope of our expectations. We need to talk to parents very openly of what is there, what we should be achieving, what we are aiming for, what is reasonable, and to try to answer the question posed by the title of my talk. Can we predict outcomes? Not in every case, but what we definitely need to be doing is to have an early referral and evaluation. So we need to start early. We need to shorten epilepsy duration. We need to think of epilepsy surgery as definitely not the treatment of last resort, and we should think of epilepsy surgery very early in these cases. We need to do a thorough pre-surgical evaluation to get as much information as possible, to be able to get arrive at the best possible decision, best possible treatment of the child. And then we need to give our best in terms of counseling. We need to give all of this information to the parents. We need to take the decision together with them to aim for the best outcomes, but also be prepared for less excellent outcomes, but outcomes that will be meaningful for these cases. And with that, I would like to thank you for your attention, and I would like to thank the organizers for organizing this excellent symposium. Thank you so much.
Thank you, Georgia. Thank you all. And now we have some questions for everyone, I think. Well, the first is from Colin Riley. Hi, Colin. Nice to know that you are watching. And Colin has one question about the term comorbidity. If we think that comorbidity is ideal and that many children have neurodevelopmental problems, often more impairing than seizures, would co-occurring be better? Terminology. Would like to answer this?
I'm happy to, but Elaine might like to go first.
Me too, if needed.
I'm happy to comment as well. I think you know, certainly I think you're definitely right. There are certain particularly genetic variants where sometimes the seizures can be quite severe and then settle, and the children are left with very significant intellectual disability and other comorbidities, although you don't want me to maybe use that word, but I think that's very true. I think you know, whether we use the term comorbidities, I think that we imply that this is really a cause, I think, of the underlying etiology for the seizures, so more the developmental encephalopathy component. I think the terminology is not so important, but I think the recognition of those and the management of those is really critical. So, you know, I think what we need to do is we need to make sure that people think about the DEEs as more than just seizures, right? So we need to address the seizures, but we need to also really focus on those other very impactful developmental, behavioral, sleep, whole issues. And so we could use the term concurrent or co-occurring. I think that's fine, but I think whatever term we use, as long as we recognize and manage those.
Ingrid?
And if I can add to that, I've given that term a lot of thought because quite a few people criticize that it's comorbidity, implying that epilepsy is the be-all and end-all and that the morbidities are just the small print. And we all know behaviour can be far worse than seizures in adolescence and even in adult life. So one of the terms we've been starting to use is multimorbidity, which is what they're using in the old end of the world in geriatric care. And that doesn't give an emphasis to just the seizures because, of course, as epileptologists, that's where we come from. So I've been using multimorbidity. I'm not mad on the concept of an extra word, Colin. That worries me because concise is better, I think. So co-occurring morbidities is a little bit, I'm not sure that I want to have those extra words, but I don't know what you think of multimorbidity. I'd be interested.
Rima?
Yes, I think that the term per se is a kind of a synonym, because when we go to the term of the comorbidity is sickness coming together. So I think that when we are going more in the etiology of all of this, let us wait a bit to change the terms, in my opinion, because going into the etiology of what is going on and understanding more the pathways of the epilepsy and the co-occurring other disorders, Colin, this is for you. I think we will be able to be more concise, but co-occurring is not shocking, in my opinion, for the moment.
Well, something that I realize is that in DEEs, it's just an opinion. In DEEs, something happened that instead of saying comorbidities, we have saying non-seizure manifestations, non-seizure symptoms, like given the same importance for both. Don't you think? Seizures and non-seizures, we are using them.
I don't like this line saying that it is seizures and non-seizures. No, it's really words matter. Let's go to the title of Elaine, because in my opinion, if we will say seizures and no seizures, what we might imply that whatever will act on one will not act on the other by nothing, and we are completely separating things. And I really believe that this putting them together was not to separate them, but was to say, when we're talking about developmental and epileptic encephalopathies, and these were long discussions with Ingrid, how we not to understand them, that seizures has no more anything to do with the development and this comorbidities or co-occurring symptoms. So I wouldn't draw a line, but it's moving so much in this moment that if we can take, maybe we will change this again, as I said before, understanding a bit more, clustering a bit more our epilepsies, and understanding a bit more from our disease modifying therapies and anti-seizure medications and their impact as a bit of disease modifying.
Okay. I have one thing here from Shahina. Shahina, I don't understand your question. If you could elucidate or expand, give some examples. I really don't understand examples of what. So if you could expand, I would appreciate, and then we can respond. Eugenia Rosa is part of the Young Epilepsy section, very active. To Professor Nabbout, do you think increasing the age limit for pediatric centers might help with transition? And have young adults still be seen in pediatric centers until maybe the age of 24, 25 would be helpful. In our country, she's in Romania, Eugenia. Malpractice laws do not allow us pediatricians to see anyone above 18. Thank you.
This is a very interesting point, and I will answer it from kind of non-epilepsy part. When your child is 18 and 2 days, and when the law is saying that he's an adult, and that he is now in charge, unfortunately, we will not be able to change the law. And I think that what we should do really is not to think that going to 21 or 22 or 24 will change the situation. What we should do really is to prepare during the years where we can act this transition. And this is why I talked much about the adults, and to find the adult group or the adult person, a neurologist, who can really be involved in for these patients to understand better. And in Paris, for instance, all the adult neurologists that will work in taking in care DEE patients in adulthood, they have a 1-year training in the pediatric institutions. This is our agreement in our program. So I think 1, 2, 3 years, we will feel better. But what about 40 years? What about 50 years? So let us keep on the low. Let us keep the 18, and let us initiate to think about that at 14, 13, take time to do it, prepare the adults, and it will be very well done if you will be involved in that.
Okay, we have 2 more questions about transition, but I will skip them and then I return just to, to circulate a little bit. You'll be back. The webinar will be available, yes, it is. I posted, and Gus also is posting in the ILAE websites and also ILAE YouTube. Eugenia is also asking to Professor Wirrell, Elaine, when do we say stop when trying to achieve seizure freedom to a child with DEEs? Is there any data on caregiver perspective on this? I think what she means is, when is the right moment to balance, to establish expectations and say, it's the moment to stop with a new drug and another one, and when is there a moment for that?
Yeah, that's a super important point. Thank you for bringing that up. I think, when we're treating a child with developmental and epileptic encephalopathy, it really is a balance, right? We're balancing quality of life and seizure control. And I think that oftentimes in my country, I see kids coming to me for another opinion, and they're on 5 or 6 medications and still having seizures. And so I think that, just having an open, honest discussion about the likelihood of complete seizure control early on in the course is really important. And together with the family, sort out goals for treatment for this child. And some families want more treatment, and even if the likelihood of better seizure control is quite low, but I think we want to make sure that we're really paying attention to the quality of life of that child too. In my practice, I think polypharmacy is very common in these children, but I think once we're going above 3, even 3 medications, if we're thinking about adding something else, then we have to ask what can go, and then start trading off. And I think that also you want to look carefully at what is the data behind what is the likelihood you're going to choose something that's going to work. So if you have Dravet syndrome and you've already been on all of the best medicines, to start pulling things, other medications out and keep throwing them at the child may not make sense. Looking at data, there was an interesting study, actually. I think Stefano Von was the lead author on that, and he looked at quality of life, or parent perceived quality of life of children with Dravet syndrome, and there was a clear correlation between parents perceiving poorer quality of life in children who had more severe seizures and more frequent seizures. So I think that does play into quality of life, but I think that again, it's a balance. I don't know if my other esteemed clinicians online have any other comments on that.
I think it could be chicken and egg too there, the quality, the sicker children have more seizures, and therefore they're on more drugs. I would like to say I kept all my patients down to 3 drugs. That's not my reality, I'm afraid. I wish it were. And I do find that I do try to take drugs away, and then their seizures escalate. So I think it's a good policy to try and reduce their drug burden because of side effects. But it's realism is very hard in this space, and you end up where you end up, often not where you want to end up, but just the way you try this drug and another drug. And the most severe Dravets, very little is working for them, even fenfluramine. Our magic bullet isn't a perfect magic bullet, as Rima and I discussed last time we met. So I think, it's a balancing act, and you've got to, but you shouldn't stop thinking. I think that's what's important. Every time you see that patient, you need to think, have I tried everything? What haven't I put together? How can I do this again? And you shouldn't do it fast. Nothing should be fast. I only increase drugs every 2 weeks. Sometimes I'll take them away more quickly. And then there might be a sweet spot where the child's really good on a lowish dose of something and another dose of something. So you have to just keep thinking very actively.
Okay. And there is one question that is under the scope of this webinar, but it's a very practical question. It's about your experience, each one of you, about hormonal therapy, mainly ACTH, but I will put as hormonal therapy versus vigabatrin for epileptic spasms, your opinion and experience. I will start with Elaine.
So I use vigabatrin predominantly for tuberous sclerosis. That would be my first go-to. I also think it can be quite helpful in focal cortical dysplasia, probably because that pathology is pretty similar. For most other cases, I do use hormonal, but I don't use ACTH. I use high-dose oral steroid. That was looked at actually by Zach Grinspan. There's a nice article in Neurology a year back or so, and it really documents that high dose, and it has to be high-dose oral steroid. It probably is equivalent to ACTH, much less expensive, at least in my country, and easier to give.
Ingrid.
I really agree with what Elaine says. I don't have more to add.
Rima.
I usually agree with Elaine, but here I have something to add. We reviewed and the paper is accepted, hopefully will be published soon in Epilepsia. Our last 15 years of experience retrospectively with this therapy. What we use in Paris is usually high oral doses of steroids, but what we use first, and whatever the etiology is, and if the diagnosis is done within 1 month of the onset of the spasm, we use vigabatrin as monotherapy. And when we take all the population, whatever the etiology is, we are able to have more than 1/3 of the patients who will be responders and who will have a long-term response, avoiding the steroids side effects. And then after 7 days, because it's a very quick action, if EEG or spasm are not responding, we add steroids, oral high doses steroids.
Georgia.
I also have sort of a conflict of interest because we have published the guidelines of the German-speaking countries, which are available online. And we are usually doing either prednisolone, not ACTH, with or without vigabatrin. And we only start with vigabatrin when we have tuberous sclerosis or a contraindication to the steroids. And it's a consensus guideline. And this is what we do in our daily practice.
So we have two good options, and sometimes combined, as in UK. I think it's reasonable to say, and it depends on the healthcare system and availability. I think that's the conclusion here. And there is one for you, Georgia. Is there a role for DBS in treating DEEs? Do we have studies being conducted or already done?
Yes, I did not have enough time to mention every possible study, but of course there is the Estelle trial on the use of DBS in Lennox-Gastaut patients, and the results are actually quite good. And there has also been a recent meta-analysis on this topic, again looking at Lennox-Gastaut patients and treatment with DBS. Of course, these are not all children, and these cases are different, and I think this is a little bit the difficulty in approaching treatment in Lennox-Gastaut because they have different etiologies, but it is definitely something to consider, and it's available. In my country, in Switzerland, or I think all over Europe, not below the age of 18, but still an option for some cases.
There is a compliment for all of you, amazing lectures, and also a question to Georgia regarding epilepsy surgery workup. And I think this is an important one. When do you request genetic testing?
Yes, so I have to say that I am the unlucky head of the epilepsy surgery program who had every possible combination of a clear-cut lesion and genetics. So we almost do genetics on everyone, unless if it is not possible because surgery has to be performed within 1 week and the lab is not so fast, or but we had cases of clear-cut tumors. This has also been published, the case of Soto's syndrome with a clear-cut tumor, and the child, of course, was not seizure-free in the end. We had a cavernoma with, again, a very complicated course. So at the time, we are really doing genetics on everyone. And it makes sense. It makes sense not only because we know what we're treating, but it makes sense also for the discussions with the parents. I think we have to do it.
Okay. Thank you. Rima, We will not have time to respond all questions, but they will be sent. No, they will be sent to those people that you are asking, and they will send the response for you. But there is one remind. What can primary care physicians or residents, what can they do to promote a better transition and referral of suspected cases of DEEs?
They should, depending on the context of their country, try to get really in contact with, if there is some expert centers or some people that are, I would say, with an advanced expertise in these diseases. They should, we are talking about residents and young fellows, we would be more than happy from our task force to do a webinar with the YES or a session with the YES group and to discuss also this. And the primary physicians, they can take the major role, in my opinion, of the coordination, which means they should develop their network of experts whenever they can. And this is what we advise them.
That's perfect. And I think we have more questions, but there is no more time because it's endless. It's coming up more and more, and a lot of compliments to your lectures. I hope you have enjoyed, and have a wonderful day, a wonderful night, evening, and thank you all. And thank you for Elaine, Ingrid, Rima, Georgia, for your time and efforts for this educational thing that we are promoting, the Pediatric Commission. Thank you all.